All right, guys, this is the second part of the infectious disease lectures. This one has quite a few slides on it, and I'm going to go fairly quickly through them. A lot of it's for your information because some of it's very advanced, specialized therapy that really is beyond most people who aren't specialists in the certain areas scope of practice, unless you're working specifically with HIV patients or with advanced infectious disease. None of this is going to really, well, I shouldn't say none of it. A lot of it's not going to really apply. So I'll try and tell you what I want you to know. And again, a lot of these slides I'm going to go through quickly. The PowerPoint's really here for your reference, not necessarily as testable material. So HIV treatment, I'm going to skip through some of the epidemiology. Suffice to say that HIV is still something we see quite prevalent, something that is prevalent in Minnesota. We're getting much better at our treatments. And we have a lot of different mechanisms for how we can disrupt the viral life cycle. And fortunately for people who get or are getting infected by HIV now, our treatments, if we're identifying early, have really good viral suppression rates. So we can really suppress viral loads to almost nothing and keep people's immune systems quite healthy and functioning. Basically, when you're looking at HIV, you're looking at two things. That's the detectable viral load and the CD4 count, which should be somewhere in the normal range. And again, with our current therapy, that's what we're trying to accomplish here. Again, drug classes are here. I'm not going to spend a lot of time on them. These are the current first-line therapies as of May of 2017. This is an area of medicine that changes quite a bit. And all I'd want you to know for a test is if I gave you a list of a patient's medications to be able to recognize what HIV drugs would look like. So they're pretty easy. I mean, anything that ends in a vir is going to be a sort of dead giveaway. Every regimen has something that ends in vir on it. And I think it's important just because if you're working with a new patient or you're reviewing your patient's medication list, as you would with any new patient, I think it's important to be able to recognize these kind of medications. You might not know if they are HIV positive. They might not come out and say that to you, but maybe if you're reviewing some of their history and you're saying, oh, they're on dolutegravir, what's that drug? Hopefully that rings a bell. That's an HIV medication. So beyond that, that's all I'm going to talk about with HIV. Again, HIV is something that's managed by specialists, not only infectious disease specialists, but a lot of specialists are just HIV providers. That's really what they do. I have a friend who practices in this area as a pharmacist, and while he has some other expertise, certainly this is his primary area of focus. And it's very complicated. It requires a lot of management, and again, that's all I'm really going to talk about because it is such specialized care. So again, these slides are here for your benefit if you'd like to review them. But for a test purpose, I'd just really like you to be able to recognize what HIV drugs look like. I skipped ahead a few slides here to the pregnancy part of HIV. Though the thing I'll say about this, because it might be more relevant to your practice, is if you are working with HIV positive patients during a pregnancy, the question is, how do you proceed with their care? So first of all, they should have an infectious disease provider on board too. That's a no-brainer, and that's a given. But it's certainly worth you knowing a little bit of the process, I think, as well. So you're going to meet standard adult criteria for treatment. If the patient does, you're going to start a combination therapy. So that slide I was just on with all the combination drugs on it, that would be something you would start in a pregnant patient, even in the first trimester. So the only drug we really avoid altogether is the drug efavirenz, which we don't use quite as often anymore. But otherwise, while they aren't ideal to use in pregnancy, the drugs are thought to be relatively safe for pregnancy use. Most of the primary regimens we're using currently. Zidovudine is abbreviated here AZT. It's kind of a weird abbreviation. But zidovudine is an IV antiretroviral agent, and it's one of the only ones we have IV, and you can use it in the time of labor followed by infusion until the umbilical cord is clamped. That can help prevent transmission. So ideally, your patient's going to have antiviral therapy on board throughout the pregnancy, therefore suppressing their viral load and really limiting the possibility of that transmission from happening. But in this case, you can give an extra drug at the time of birth too. My colleague and friend who works for Hennepin County in HIV has said that they haven't actually had a vertical transmission in several years. Because of the practices they've put into place and because these drugs are so effective now, we can really make sure that those babies are born completely healthy, which is actually a pretty cool thing if you think about how far HIV therapies come. People wouldn't have been talking about that 20 years ago. So this is pretty cool. as a prophylactic measure, you do treat the baby for 6 weeks after that. You use oral zidovudine twice a day for 6 weeks. And then if the mother was not on any therapy during pregnancy, so if they were uncontrolled HIV infection or had a high viral load, you might want to be more aggressive than that. But basically, a single drug therapy as prophylaxis is usually effective enough to just cover all your bases. Okay, some other more common viruses. HSV, something that is a lot of people are exposed to, and whether it's going to be different types of cold sores or chickenpox or what have you, there's lots of different types of HSV. So HSV type 1 and 2 are your typical cold sores. So 1 is kind of considered the above the waist. That would be the oral cold sores that are more common. And type 2 would be considered more the genital, sexually transmitted version. However, both types can present either way. They're very similar in presentation. So it's just one prefers one area of the body, the other prefers the other area, but they really don't. They don't have they aren't that selective about where they're going. The rest of the HSV types are over here. I'm not going to go through them specifically because from a treatment point of view, we don't really do much with them. This is really where you're going to see the average person having reporting to a physician's office because they're getting cold sores or maybe they have a genital infection. This is a fun fact from one of my friends gave me this one. Up to 95% of prostitutes have been exposed to HIV as opposed to 3% of nuns. So there you go, in case you want to share a fun fact with somebody for the day. Anti-HSV drugs, there's really one drug we're most concerned about, and that's Acyclovir. Valacyclovir is just a oral available form of Acyclovir that absorbs a little bit better. So basically, these two drugs are the same. There's some other options like famciclovir and docosanol, which we'll talk about very briefly here, but let's talk about Acyclovir. Acyclovir is available oral and IV. What it does is it inhibits viral DNA synthesis by terminating, it's a chain terminator, so it adds on to the replication step, and then the virus can't complete its replication. It's only IV agent, so if you need IV therapy or if you have a HSV-related meningitis, Acyclovir is going to be your drug of choice. But as far as an oral therapy, it's dosed about 5 times a day, so it's really inconvenient. It has a very short half-life. It is, generally speaking, okay to use in pregnancy, though. Valacyclovir was a formulation of the L-ester of acyclovir that's rapidly converted to acyclovir following PO intake. However, you get about 3 to 5 times higher serum concentrations absorbed into the bloodstream from the GI tract than with regular acyclovir. So you can dose valacyclovir usually twice daily is what's most common, but depending on the indication, you might see once daily for prophylaxis. You might see 3 times daily for more severe infections, but generally for cold sores, you're looking at a twice daily dose. It is a drug of choice for oral genital herpes just because it is much more convenient than standard acyclovir for patients. One thing to think about is that this drug used to be kind of expensive, so I think that limited people's use of it. However, now it's generic and it's relatively affordable. So at one point, yeah, people might have still used acyclovir quite a bit because even though it's inconvenient, it's cheap. At this point, valacyclovir should be relatively inexpensive too. This one is PO only. It does not have an IV form. And both of these drugs have very few side effects associated with them, which is always a good thing. Hepatitis treatment is another thing I'm going to go through very quickly. Hepatitis A is a virus that is usually self-limiting. It's fecal-oral transmission, usually associated with poor water quality in usually developing countries. So this is a vaccine that we'll give people if they're going to be traveling to some place that has less high water quality standards than other parts of the developed world. But basically, there's no specific treatment. You wash your hands, you hope you don't get it, and you get the vaccine. If you do get it, it's usually self-limiting. Symptoms might last for 2 months and be unpleasant, but your body will clear it eventually. Hepatitis B is a widespread infection worldwide, and there's lots of people that have hepatitis B that are carriers that aren't necessarily actively showing symptoms with it, and it's a very common disease in the developing world. So over 1 million people die from cirrhosis and hepatitis C related complications. There's about 3 phases of this thing, and the big thing is a vaccine. So a vaccine can prevent the transmission of this. The reason why we give people, this is one question that comes up every once in a while, the Hep B vaccine is the first one children get in the hospital. So the question is if you're hesitant about vaccines, do I need to give my baby a vaccine that early? The reason why is because the idea is that while you're in the hospital, you're most likely to come in contact potentially with hepatitis B due to possible bloodborne pathogen. Possible transmission is higher than you would maybe associate being at home or in the community or going out and about in public. You aren't really going to get hepatitis B from that, but in the hospital, you do have a higher risk. That's why they tend to give the vaccine earlier. Treatment I'm not going to go through. It's complicated. Hepatitis C is another pretty common illness, and it's one that is highly treatable at this point, actually. This is recent. Within like the last 5 years, our hepatitis C treatments have really exploded. They've developed a lot of interesting antiviral combinations that are once daily. They're relatively well tolerated for patients, and you can end up curing the patient with a year course, sometimes a 2-year course, depending on how long or how effective the person's responding to it. So this has been a real game changer when it comes to Hep C treatment, and it's been something that has really opened up a couple controversies. The first one is being that these drugs are really expensive. So a course of Harvoni is like $100,000 to $200,000. But the argument is that, well, this is a cure. So if you think about it, if you're giving somebody a drug for high cholesterol or high blood pressure, that person is probably going to be on that drug for life, or probably for most of their life. That's a lot of money that pharmaceutical company is going to reap in over years and years and years. Whereas with this drug, they're on it for a year or two, and they're fully cured, and then they never have to take it again. So drug companies will say, well, if we're only getting a year's worth of use out of our product, and eventually, if everybody takes our drug, everybody's going to get cured of this, and we aren't going to have any business left. We got to make money while we can because we invested a lot into the research. So no matter how you think of the business practices of drug companies, the cold hard logic does sort of make sense. I'm not saying I agree with it. I'm just saying that's the logic behind why Harvoni and other drugs like this are so expensive. But most insurance programs are paying for them just because simply the cost of investing in a cure for hepatitis C is much less than if you have somebody going into the hospital, into ICU care, needing a liver transplant with advanced cirrhosis. That gets really expensive really quickly. So ultimately, this is an investment in the person's long-term health and theoretically would save money down the road. All right. Influenza. Influenza is something that affects about 250 million individuals annually. The annual cost is about $37 billion. It's a very high cost illness, and it's something that's very tricky because we have a vaccine for it, but as you've probably heard over and over again, the flu vaccine isn't the most effective vaccine we have in the world. Effectively, this on a good year, it's like if you can get like a 60%, 70% response rate, that's pretty good for the flu vaccine. The problem is there are a lot of different influenza subtypes floating around out there throughout the world. So what our epidemiologists at the CDC try and do every year is look at global trends and figure out, okay, these specific strains are being seen in Asia this year in big quantities. They probably will come to the US at some point. And then we try and build our vaccines off of those. So our vaccines usually have 3 different types of influenza A and one type of influenza B as the ones. And so when you hear about H1N1 or H3N2 or whatever the subtypes be, those are different types of proteins which are expressed on the influenza capsule, and those make up the different ones. So when we're making a vaccine, we have to target a specific subtype of an H something N something virus. And if we mess up, if we predict H3N2 and it's H1N1, then we're in trouble. We aren't going to get it. And every once in a while, like when the H1N1 was a big deal a few years ago, they actually came out with a separate vaccine for that subtype because they thought it was going to be such a big outbreak. And there was some issues with it, but it wasn't as big as it could have been simply because part of it because they had a additional vaccine they created just for that one that they missed in the prediction of what strains were going to come to the U.S. Transmission, respiratory droplets, rapid onset, headache, fever, muscle pain, non-productive cough, and sore throat are the first symptoms. Influenza is usually an upper respiratory at first, and then it goes into a lower respiratory symptom. One thing about influenza that people should know is that, and that you hear a lot, is, oh, I've got the flu. I was, throwing up forever. Well, that's not influenza. Influenza generally does not affect the GI tract. Sometimes in little kids it can cause some GI symptoms, but generally in an adult it's not going to cause GI symptoms. That's going to be a norovirus or food poisoning or something like that. One of the problems with influenza itself usually doesn't kill people. It's things that come with it. So if oftentimes the respiratory tract gets irritated, there's a lot of inflammation going on, and that can lead to the immune system's kind of out of whack. You can end up with a comorbid bacterial pneumonia, and a lot of times what we'll see is MRSA pneumonia or Streptococcus pneumoniae. And those can be really devastating. That's where you see young people usually dying from influenza, or young healthy people, where we'll see them in our ICUs because they have a really nasty pneumonia that came from an original influenza infection. So it's a co-infection that you're seeing cause the morbidity and mortality associated with this. Prevention vaccine, remember there's an IM, there's an intranasal. Usually you're looking at average year, probably we're seeing about a 50% reduction in influenza and about 70% reduction in hospitalizations with the influenza vaccine. So even if the vaccine isn't fully effective, usually even if you're vaccinating against the wrong strains, if you do get a different strain of influenza, your body is going to be able to react a little bit faster, theoretically, and your symptoms will be less. So usually it's thought that if you've got the vaccine, you're going to have a more mild influenza if you do happen to get the flu during that year. Kids 2 months to 8 years should get 2 vaccines once. And then adults will get the once yearly vaccine. And pretty much everyone should get vaccinated. There's really very few contraindications, and there's even an egg-free product here. Neuraminidase inhibitors. Tamiflu is the big one here, and that's a drug used for treatment of flu. We start this within 48 hours of symptom onsets. Once you're out of that 48-hour window, Tamiflu is not effective. So really you have to catch it right away. It does decrease the duration by maybe about 1 day. And the severity is supposed to be significantly diminished as well in secondary complications. So even though Tamiflu outcomes aren't great, it still does help usually. So we still give it to people who test positive for flu and are within that 48-hour window. Amantadines I'm not going to cover. These are not endorsed by the CDC since the H1N1 because there are some strains and variants are resistant, so we don't really use them anymore. Sometimes they used to use them in nursing homes for outbreaks, but they pretty much use Tamiflu now for that. All right, HPV, there is a vaccine for this, Gardasil, and then there is a newer vaccine as well that I didn't put on here that covers some it's the Gardasil 9. So Gardasil regular covers these 4 strains. Gardasil 9 covers several other strains. And these added strains are thought to be other strains that rarely cause cervical or penile cancer. There's a topical product called imiquimod, which is a cream that you could put on genital warts as well to get rid of them. It does take quite a while, though. Antifungals, another area of medicine that there's not a lot of applications for us to discuss, but there are quite a few drugs that are available. And so again, unless you're working in a specialty infectious disease, you aren't going to use many of these medications. Fungal infection risk is usually for immunocompromised, people on broad-spectrum antibiotics, critically ill patients, people who are really, really sick, septic, and not responding to standard antibiotics. That would be a fungal candidate. There's a couple different types of fungi and several different infections. So the most common one that we might see in community practice or in your practice would be Candida infections. And this is going to be common things like thrush or yeast infections. And we're really going to use basic azole antifungals. So ketoconazole is something that can be used topically. It's not used very much anymore. Azole antifungals are generally avoided in pregnancy. However, fluconazole is a drug that's very handy in using for empiric Candida infections. So this is where things get a little tricky because fluconazole has some contraindications in pregnancy, but there's been a lot of studies in fluconazole use in pregnancy, and usually if you're sticking to small doses over short periods of time, fluconazole is thought to be relatively safe. So like the one-time dose for oral candida infections or vaginal yeast infections is usually okay during pregnancy. Now you can certainly use topical products for that too, like oral rinses or vaginal suppositories or creams like miconazole. But fluconazole is something that orally is used. Now, if you're going to do something sustained, like a longer-term course at higher doses in pregnancy, you'd want to avoid it. But generally speaking, the low doses are likely quite safe. I'm not really going to talk about any of these other antifungals because they're systemic. They are used for really nasty infections, and you aren't going to be prescribing them. This is going to be ID specialists only. They're here for your reference, kind of like the HIV stuff. I will talk about some other stuff quick. Clotrimazole and miconazole are topical products that come as creams sometimes for things like common names, like mostly tinea infections like ringworm or jock itch or athlete's foot are all different types of tinea infections. They're available as vaginal creams as suppositories too, like brand names such as Monistat. Terbinafine is another one that's a topical product that could be used for other tinea type infections. Malaria is a final topic here, and knowing something about malaria is useful for prescribing for preventative medicine if people are traveling, your patients are traveling abroad. Malaria is a really common infection in a large part of the world, not really in the US, mostly due to our climate, and not really having the specific type of mosquito that transmits it here very much, but it's a huge source of deaths, 1 to 2 million people per year worldwide. The CDC, I just took a snapshot of this. So CDC will show you what types of recommended prophylaxis to do. So if your patient's traveling to Afghanistan, it says estimated risk is high, drug resistance of chloroquine, recommended atovaquone proguanil, doxycycline, or mefloquine. So there's a couple options there that are recommended. Here's a cycle of the the mosquito, I'm getting Lyme disease now, mosquito transmitting the parasite. Preventions, so all our regimens vary in cost. They have adverse effects and dosage schedule differences, but the CDC generally has the recommendations, so I would follow them. The most common drug out there is Malarone or atovaquone proguanil. It's an easy regimen, so you start 1 to 2 days before you travel. You take it every day during your travel, and you take it for 7 days following. That's well tolerated. The one issue which might come up with your patients is it has pretty limited pregnancy data. So in that case, we might have to try something else. Mefloquine is another one that is safe in pregnancy that could be used. Its dosing schedule is a little more complicated. You take it once weekly, which right off the bat is very difficult for most patients to remember. Most patients can remember daily meds, but once weekly, it's really challenging. You have to set up weird reminders, and pill boxes aren't set up that way. So the odds of compliance with something like this, I'd say, are slim, but it's worth a shot potentially. But you take it once weekly, start 2 to 3 weeks before, and take it during your trip and 4 weeks after. This has some really weird side effects. There's GI side effects, but there's a small percentage of psychiatric side effects that people can get, more common in women and more common in people with a history of mental illness. So if you have a patient who is a woman with a history of some sort of psychiatric disorder, I'd probably recommend avoiding mefloquine, even though it is safe in pregnancy. What you could do is start 4 weeks prior to their travel, so give them 2 weeks of sort of a trial period and see how they're doing with the psychiatric related side effects. And if they don't get them, maybe it would be safe. So you could do a trial period like that. Doxycycline is an option as well. It's 1 to 2 days before and 4 weeks following. So it's quite a long course that you have to take afterwards. And most people won't finish it. They'll get home, they'll feel fine, and they'll stop. So why it's recommended for such a long term, I'm not exactly sure, but it just is. It is contraindicated in pregnancy in children, though. Chloroquine's another one that's useful in pregnancy. However, this is one that's highly resistant throughout the world, so oftentimes this is not an option for most people. Primaquine is contraindicated in pregnancy and breastfeeding. It's a more obscure regimen. There are some active treatments, which we rarely ever see in the United States, an active case of malaria. And if we do, we have to get the MDH or CDC to sign off on obtaining these. I had to actually do this recently, right, to call the CDC out of Chicago at like 7 o'clock on a Friday and coordinates a drop shipment of one of these medications in. So you will get that occasionally, but it's not something you'll have to deal with. So, all right, that's the rest of infectious disease in a nutshell. Pretty quick. As far as focusing on things for the exam, again, recognizing HIV drugs, being able to identify the basic treatments for HSV infections, specifically cold sores, knowing basic antifungals such as fluconazole and some of the topical products that you might use, and then maybe a little bit about malaria, but that's pretty much it. So thanks for listening, guys. We'll talk to you soon here.